Hello, everyone. This is Dr. Kuo. Today, we'll be talking about blood vessels. We'll be discussing exactly how they are able to generate pressure and propel the blood flow throughout our cardiovascular system. This is a simplified functional diagram of the cardiovascular system. As we talked about in the previous lecture, the heart has two sides. Okay, so we have the right heart and left heart, and they lie in series. Connecting between them are the pulmonary circuit and the systemic circuit. Whereas the left heart pumps blood through the systemic circuit, the right heart pumps blood through the pulmonary circuit. Okay. And so the left heart, left ventricle specifically generates the pressure that propels blood into our systemic arteries. So first, the blood is going to pass through elastic arteries. Okay. And these elastic arteries, as their name implies, they have elasticity. So they're able to expand, okay, and then preserving that pressure. Okay. And as the heart begins to relax, their walls bounce back. Okay. And that pressure is now able to ensure the continuous flow of the blood into the downstream arteries. So in that sense, they serve as a pressure reservoir. Then the blood flows into muscular arteries. Muscular arteries include most of the named arteries that we know of, those that branch to form arterioles. Arterioles are able to constrict, dilate, especially in response to the autonomic nervous system innervation. So we are able to significantly control and vary their resistance. Okay, so they have an important role in control of blood pressure. Okay, and then these arterioles eventually branch to form capillary beds, which are embedded within different tissues. And these capillaries, having really thin wall, allow for rapid and efficient exchange of nutrients and waste between blood and those tissue cells around our body. Okay, and then those capillaries then merge to form venules, which are tiny little veins. Okay. And then venules eventually merge larger and larger veins. Okay, eventually the vena cava, and then back to the right atrium. So we can see here that systemic veins, because they are wider, okay, and they're able to serve as a volume reservoir. Okay, so at rest, about 2/3 of the body's blood volume is actually contained within the venous side of our circulatory system. Total blood flow through any level of the circulation, whether we're looking at these elastic arteries or muscular arteries or arterioles or capillaries or venules or veins or vena cava. So at any of those levels, the total blood flow is equal to cardiac output. Okay, so that means if we measure the rate at which blood is passing by this point, okay, across all the capillaries, that will be also the same as the cardiac output. Okay, same thing here across all the pulmonary capillaries at that given time. Okay. And so, for example, if cardiac output is 5 liters per minute, that means the blood flow through all the systemic arteries is also going to be 5 liters per minute. Okay. And likewise, blood flow through pulmonary side of the circulation is going to equal to the blood flow through the systemic circulation. Looking at the wall composition of blood vessels allow us to determine and understand its function. The walls of different blood vessels can vary significantly in their diameter and their wall composition. Arteries in general will have a thick layer of smooth muscles compared to veins, okay? And there's also plenty of elastic tissue. So compare the diagram as well as this column about relative tissue makeup. So a lot of smooth muscle in that tunica media, okay, and elastic tissue, okay, relative to veins. You can see that veins, okay, have center walls, and they have predominantly the fibrous tissue in that tunica externa. Okay. So what all those elastic tissue and smooth muscle in arterial wall mean is that it takes more energy to stretch the walls of an artery outward. And but that energy can actually be stored by the stretched elastic fibers and released when it recoils. As major arteries branch to form smaller and smaller arteries and arterioles, their walls also become less elastic and more muscular. And so the walls of arterioles in particular have several layers of smooth muscle that allow them to contract and relax under the control of various chemical signals, including innervation by the autonomic nervous system. So of these arteries, elastic artery is not able to vasoconstrict that well. Okay, it's able to expand and recoil, but it's not very active in vasoconstriction. On the other hand, muscular artery and arterial are both active in vasoconstriction. They're able to constrict under the influence of those hormonal or chemical signals. So examples of elastic artery include aorta, brachiocephalic trunk, common carotid arteries, subclavian arteries, common iliac arteries, etc. Okay, these arteries are nearest the heart and that contain much more elastic tissues in the tunica media compared to muscular arteries. Okay. So elastic arteries, because of their ability to expand and recoil, these are important in serving as pressure reservoir. Muscular arteries and arterioles are active in vasoconstriction, so their importance is in their control of blood pressure. Okay. Capillaries have really thin walls. They allow for efficient exchange with nutrients as well as waste. Okay. And venules, veins, especially the larger veins, they have a thin wall. Okay, so they serve as capacitance vessels. In that sense, they are able to serve as volume reservoir. They can contain a lot of volume of blood. Now we're ready to delve into understanding the concept of blood pressure, blood flow, as well as resistance of blood vessels. Blood pressure, sometimes you'll see this written as this Greek letter delta with P. The delta is referring to a change in pressure. P is pressure, right? So when we talk about pressure in physiology, we're always talking about relative pressure, okay? And the way we can measure pressure is the difference of pressure taken at two different points. So blood pressure is defined as force per unit area exerted on a blood vessel by blood. And it's oftentimes expressed in the unit of millimeters of mercury. So the pressure gradient, or the delta P, provides a driving force that ensures blood flow continuing to flow from higher to lower pressure areas. Okay. So as we discussed before, once the blood is ejected by the left ventricle, the arteries in aorta expand to accommodate it, okay? Specifically the elastic arteries, including aorta. And when the ventricle relaxes and the aortic valve closes, the elastic arterial walls will recoil, propelling the blood to continue moving forward into smaller arteries and arterioles. And by sustaining the driving pressure of blood flow during ventricular relaxation, the arteries keep blood to flow continuously through the blood vessels. If it wasn't for this property of elastic arteries, you can imagine that every time ventricles contract, places higher up in your body, such as your brain, would receive oxygen or receive blood with the oxygen they carry. And then as soon as the valves close and the ventricle begin to relax, that blood supply will then be cut off and you would faint basically with every heartbeat, right? So this elasticity in the elastic arteries ensures that blood flows continuously into those tissues. This is a graph showing blood pressure throughout the circulatory system. We can see that blood pressure is at its highest on the arterial side, and then it falls as we get to capillaries and then the venous side. Okay. And also notice the pulsatile nature of the curve, the peak of which is systolic pressure, and then lowest point for these pressure is the diastolic pressure. And so the pumping action of heart generates blood flow, and pressure results when the flow is opposed by vascular resistance. Okay. And with the vascular resistance, the pressure continues falling as we get to the capillaries. Okay. And the low pressure here is useful because otherwise we could rupture the thin capillary walls. Okay. And then the blood pressure continues falling on the venous side. There's a small gradient, small pressure gradient from the venules to the vena cava. Okay. The low pressure in veins is due to the cumulative effect of peripheral resistance going from the arterial side all the way to the venous side. Okay. And the pressure is too low to promote any adequate venous return. And so we've discussed some of the adaptations on the venous system that allow for venous return. So that includes the one-way valves, okay, the muscular pump, respiratory pump, etc. Blood flow, sometimes symbolized with the letter Q, measures the volume of blood flowing through a vessel or multiple vessels or an organ or entire circulation within a given period. So it's measured in a unit of volume over time. Okay, so this could be milliliter per minute, milliliter per second. It could be liters per minute, liters per second, etc. Okay, and so cardiac output, as we previously learned, average cardiac output is generally around 5 liters per minute. Okay, and so that will be the blood flow through the entire cardiovascular system. Okay, so remember that volume over time is a unit, and that blood flow measures rate. Okay, the rate at which a certain amount of blood is flowing. Arterioles, along with capillaries and venules, form microcirculation, and we can regulate the amount of blood flow through microcirculation through the action of these precapillary sphincters. You can see that true arterioles are continuously covered with smooth muscle, whereas meta-arterioles, they are only partially covered by the smooth muscle. Okay, and so let's say that there is now less demand in oxygen by the specific tissue, and then increased demand of oxygen at another tissue. Then for these precapillary sphincters, they can then constrict, limiting the amount of blood flow through this capillary bed, and blood will then directly be directed through the meta-arterioles to the venous side. And in this way, we're able to redirect more blood volume to be supplied to other organs. The resistance of blood vessels, abbreviated R, measures the opposition to flow within blood vessels. And there are a few important factors that play a role in determining the vascular resistance. One is how thick the blood is. So in other words, fluid viscosity. Okay, and this is the Greek letter eta. Okay, so you can see that viscosity is directly proportional to resistance. That means if you increase the thickness or viscosity of blood, you're also increasing resistance. We have the same relationship between the length of blood vessel as well as the resistance. Okay, so increasing the length, a longer blood vessel would have more resistance than a shorter blood vessel of the same diameter. Finally, the radius of the tube or radius of the blood vessel. Okay, this is the most important factor. Okay, you can see that resistance is inversely related or inversely proportional to the fourth power of the radius. Okay, that means a change in twofold of radius can change the resistance by 16-fold, for example. Okay. And the relationship of these factors to resistance can be summarized by Clausius' law. Okay, so understand Clausius' law. This is viscosity, this is the length of the vessel, and this is the radius of the blood vessel. Okay, and notice that the first two factors stays relatively constant. Okay, the thickness of your blood generally doesn't change that much. And the length of your blood vessel, okay, also is relatively constant over time. And this final factor, the radius, is the one that can be rapidly and significantly altered. Okay. Here we have an example looking at the influence of varying blood vessel diameter, which is just twice the radius. What it has, the sort of influence it has on resistance. Okay, so we can see that halving the radius, going from 2 millimeter to 1 millimeter, okay, is able to multiply the resistance by 16-fold. So this example helps us understand part of why hypertension and atherosclerosis can be dangerous, especially if it's long-term, right? When you narrow the lumen, okay, of these blood vessels, you're increasing vascular resistance. And with higher vascular resistance, your heart will have to now work harder, contract harder in order to overcome that backward pressure coming from the resistance of the blood vessels. Now let's take a look at the relationship between blood pressure, blood flow, and vascular resistance. So this is a formula that you should commit to memory and make sure you understand what it stands for. Pressure, the pressure gradient, is the difference between pressure at two different points. Okay, it is directly proportional to blood flow and vascular resistance. Okay, in fact, it's a product of the two. And so that means you can increase blood pressure by either increasing blood flow or increasing resistance, or both. Okay, and don't confuse big R with a small r. Small r is the radius, right? Big R stands for the resistance. Okay, you can rearrange this formula to Q equals P over R and say that blood flow can be increased by either increasing the pressure gradient or decreasing the radius. Okay. As our ventricles contract and force blood out into the arteries, these blood vessels expand and the pressure rises to a maximal pressure known as the systolic pressure or systolic blood pressure, SBP. And this is generally on average around 120 millimeters of mercury in adults. And as the ventricles relax, the pressure then falls to a minimum known as the diastolic pressure or diastolic blood pressure, DBP. On average, it's about 80 millimeters of mercury in a healthy adult. Okay. And because of the pulsatile nature of arterial blood, we can measure the pulse pressure, which is the difference between systolic pressure and diastolic pressure. And because of this pulsatile nature of blood flow on the arterial side, it's this constant cycling of rising and falling of blood pressure that is the source of our pulse. And you can actually feel the pulse under your skin. Also notice in this diagram that the pressure in the ventricle falls a lot more drastically. And so as the ventricles relax, the pressure actually falls to only a few millimeters of mercury. But compared to that on the arterioles, on the arteries and arterioles, you'll see that the diastolic pressure in these larger arteries in particular remain relatively high. And the high diastolic pressure in arteries actually reflects the ability of these vessels to capture and store the energy in their elastic walls. Okay, so pulse pressure equals the difference between SBP and DBP. And then we have mean arterial pressure, and that's because ventricular pressure is difficult to measure without invasive procedures. And so it's customary to assume that the arterial blood pressure reflects ventricular pressure. And since arterial pressure is pulsatile, we turn to a single value, the mean arterial pressure, to represent driving pressure. And in this case, mean arterial pressure can be calculated by DBP, diastolic blood pressure, plus a third of the pulse pressure. That's mean arterial pressure. This slide reminds us that because of the low pressure gradient from venules to veins, our body has several mechanisms that help to ensure adequate venous return back to the heart. And these mechanisms include the muscular pump, which involves skeletal muscles milking blood back to the heart. We also have the one-way valves that prevent backflow. And then we have the respiratory pumps that involves drop of intrathoracic pressure during inspiration, causing pressure inside the right atrium to also drop. And then that increases basically the pressure gradient between vena cava and right atrium, and then helps increase the blood flow into the right atrium. We also have sympathetic venal constriction. So under innervation of sympathetic nervous system, smooth muscles constrict, and that helps bring more blood back to the heart. Let's now talk about normal blood pressure, hypertension, hypotension. So hypertension and prehypertension definitions. Hypertension is defined as blood pressure 140 or above, or a diastolic blood pressure of 90 or above. Okay, so it's either or, but you can also have both elevated. And then there is a level between normal blood pressure and hypertension called the prehypertension. And this is defined by blood pressure, systolic blood pressure between 120 and 140. Okay. And diastolic blood pressure between 80 and 90. Okay. So before 90, basically from 81 to 89. And then systolic is between 121 and 139. And then normal blood pressure is generally considered 120 or less, with diastolic pressure being 80 or less. So remember these values. Now, hypertension can come from a wide range of causes, and these causes can, generally speaking, be classified under either primary hypertension or secondary hypertension. Now, 90% of cases, or 90+% of cases of hypertension are primary hypertension. That means most people who have hypertension have primary hypertension, also called essential hypertension. This type of hypertension is multifactorial of cause. Okay, that means it's linked to a combination of age, heritage, their race, obesity, diet, smoking, other comorbidities like type 2 diabetes. So generally speaking, there's no clear cause. Okay, and the general treatment usually involves a combination of treating the modifiable risk factors like control weight, right, lipids, antihypertensives, etc. The less common category in terms of the cause of hypertension is called secondary hypertension. And this is generally only about 10% of all people with hypertension. And this is less common, and it involves identifiable causes. And so, for example, kidney disease, adrenal disease, endocrine pathology, vascular malformation, etc., leading to their hypertension. And so in secondary hypertension, instead of treating the modifiable factors and using antihypertensives, it's more useful to treat the underlying cause. Okay, so if it's a renal artery malformation, then they have to do a procedure on that renal artery, for example. This slide goes over the process of measuring blood pressure. So when you take someone's blood pressure, you inflate the pressure cuff to a pressure so high that it stops the blood flow. Okay, and usually we use the arms, so this would be the brachial artery. Okay, so that pressure stops the blood flow. And then we open the valve so that the air starts leaking, and then the pressure begins to drop slowly. Okay, and then we listen with a stethoscope. And you also see the needle jump when we reach the systolic blood pressure. Okay, and the first sound that you hear through stethoscope, also signified by the needle jumping, okay, is the systolic blood pressure. And then as you continue to let more air out, okay, you'll eventually hear the last sound before the blood flow becomes silent. So that last sound signifies the diastolic blood pressure. And by convention, blood pressure is written as systolic pressure over diastolic pressure.